Hip fracture. Hip fracture. The fracture of the femoral neck. Examples: a fall in an old person with osteoporosis. Typical: a high-energy trauma, such as a motor accident, gunshot wound, or jump or fall from a height in a younger person. Risk factors: women, older people, osteoporosis, unsteadiness of gait and reduced bone, mineral density, cognitive impairment. Types: intracapsular fractures, femoral neck fractures, avascular necrosis or Malunion of the head of femur due to the limited blood supply to the area. Type 1, undisplaced and incomplete fracture. Type 2, undisplaced complete fracture. Type 3, complete fracture but incompletely displaced. Type 4, complete fracture and completely displaced. Extracapsular fractures. Intertrochanteric fracture. Avascular or nonunion necrosis is rare because of a good blood supply. Subtrochanteric fracture. Treatment: usually a combination of surgery and rehabilitation. Also depends on the location of the fracture and whether it is displaced. Non-operative management: bed rest and traction. Significant complications such as avascular necrosis and non-union are very common. Operative management: reduced length of hospital stay and improved rehabilitation. Internal fixation: performed with multiple pins, intramedullary hip screw, crossed screw nails, or compression with a dynamic screw and plate. Replacing the femoral head: prosthetic replacement, with either hemiarthroplasty or total hip arthroplasty. After surgery, prolonged bed rest can increase the risk of pressure sores, atelectasis, pneumonia, deconditioning, and thromboembolic complications. Complications after surgery involve blood clots, pneumonia, wound infections, and more. All of them can be reduced with activity. Risk of avascular necrosis, AVN, depends on the type of fracture. Transphysial: approximately 90% subcapital, approximately 50% basicervical, transcervical, approximately 25% intertrochanteric, approximately 10%. Main consequences: high mortality, long-term disability, huge socioeconomic burden.